Yes, we are live now also in YouTube, and with all your permission, we are starting with our today's session. A very good afternoon and a warm welcome to all the doctors present here. I am Debulina, the designated moderator from Clarnet side, and Clarnet is very proud to be a part of this webinar as a digital partner. So with all your permission, I will be sharing a short video of Clarnet. Clarnet is India's largest live digital CME and a doctors-generated medical content platform, which is exclusively free for all the medical practitioners. So here is a short glimpse of Clarnet. Thank you so much, all the doctors, for your patience. Our website is www.clarnet.com. And I would request every doctors kindly do visit our website to get all the health updates on different topics and specialty. So now, without further ado, I would like to hand over the session to Dr. Prashant Karia sir to start with our today's session. Over to you, sir.
On behalf of NNF Gujarat, I, Dr. Prashant Karia, the Secretary of NNF Gujarat, welcome one and all to today's neonatal Pathshala. I request our advisor, Dr. Somsekhar sir, to start the function.
Yeah, good afternoon, everyone. So it's my proud privilege to introduce Dr. Burak Salgin. He's from the UK. And I'm just sharing this as a primer before we go to the actual program. Dr. Burak, we actually conduct this program as an educational program every Wednesday. And we have Dr. Burak today for a few minutes initially to discuss about opportunity in the UK. We will have a detailed session later on, probably in April, but currently, so Dr. Burak, as you can see, is a considered neonatologist at the Royal London Hospital and Queen Mary University of London, with interest in resuscitation, transplant medicine, and physiological data acquisition and analysis. So we have discussed together on the opportunities for postgraduates in pediatrics to go to the UK after following the MD, and we would like Dr. Burak to maybe speak about it for a few minutes now before we start the actual program. Thank you, Dr. Burak, and over to you.
Thank you so much to you and to everyone for inviting me. This is great. I'm looking forward for what is to come. And you're quite right. I'm ever so keen, together with my colleagues, to open up educational opportunities for your junior and more senior middle grade doctors at the Royal London Hospital, and also with the neonatal transport service in London, which is unique in the whole country, as it's the busiest transport service in the whole of the UK, with more than 2,000 referrals a year and a complete intensive care unit on the roads with dedicated ambulances. And starting September this year and March next year, I'm ever so keen, with your help, to open up these training opportunities for 6 months up to 2 years, if not more, if that fits in with your training, to not only work with us on the unit at the Royal London Hospital, which is a tertiary medical surgical centre that's soon to be 45 bedded, with 13 consultants and 7 pediatric surgeons in all pediatric subspecialties, as well as the transport service, of course, which is also housed at the Royal London Hospital for the whole of London. So I'm looking forward to coming back and giving you more details on our services and our training program.
Thank you, Dr. Burak, for a short overview, and we'll probably have a longer overview at some point of time in the coming weeks. So in case anyone wants to have more details, you can just message me at my number, 9825087842, and I can send you more details after that. Back to Dr. Prashant for conducting the rest of the session. And Dr. Burak, you can hang around and be here, and maybe you're free to leave if you need to leave at some point, any point of time. Thank you.
Thank you so much, Dr. Burak and Dr. Somsekhar. Just to tell everyone, those who are on Clarnet platform as well as YouTube, for further information, you can contact Dr. Somsekhar. Now I request our President, Dr. Dipen Patel, to welcome one and all.
Thank you, Dr. Prasant Bhai. On behalf of NNF Gujarat, we welcome you all on this 9th consecutive neonatal Pathshala. Today we will be discussing neonatal necrotizing enterocolitis, a very common topic, and we need to learn in depth. So we have a case presentation by Dr. Parth.
Muted.
I thank Dr. Parth Patel for being a presenter and Dr. Sachin Shah, who is a mentor of this lecture and case series. So I thank Dr. Kamal Parikh and Dr. Patel for being a moderator. Over to you, Dr. Prasan Bhai.
Thank you so much, Dr. Dipen Patel. Now, without taking much of a time, as Dr. Dipen Patel already said, Dr. Parth Patel is a fellow in neonatology at Anand Children Hospital. He is doing fellowship at present in Anand Hospital, Surat. And Dr. Sachin Shah Mentor is a neonatologist, a chief neonatologist at Anand Hospital. Today, we'll be having a moderator, that is Dr. Snehal Patel. She is practicing neonatologist at KD Hospital, Ahmedabad. Her main area of interest is neonatal ventilation, point of care ultrasound, and neurodevelopmental follow-up of NICU graduate. She's having many publications in national journals, and she was editor of Gujarat Neoblaze magazine from 2019 to 2020. So I request Snehal to introduce both the speakers, experts today. Thank you.
Thank you, Prasant Bhai. And thank you, the NNF team, to give me an opportunity. Today, we are going to discuss an NEC, a hot topic in neonatology, isn't it? And we have an esteemed experts with us, Dr. Kamal Parikh and Dr. Akash Sharma for the same. Dr. Kamal Parikh is a senior neonatologist in Ahmedabad, practicing in Kamal Children Hospital. And he has been awarded for the Limca Award for surviving the 468 grammar baby. Welcome, sir. And we do have a Dr. Akash Sharma. He's an assistant professor in neonatology in Jaipur AIMS, having more than 1600 publication in index journal. He is heading the department. Welcome, sir. And we have a young neonatal fellow, Dr. Parth, who is doing his fellowship in Anand Children Hospital. Welcome you all. And I request Dr. Parth to be a little crisp and brief in his presentation.
Okay, ma'am.
Yeah.
Hello, am I audible?
Yes, Parth.
Yes, you are. Yes, you are.
Good afternoon, everyone. Thank you, NNF and Neonatal Pathshala, for giving me this opportunity. Today, we all know that NEC is the most old and recent hot topics in neonatology. After so many years from the beginning and now, we have the so much recent advances. And now from the treating the NSC and diagnosing the NSC, we are shifting from the prevention part of it. So today our aim is from beginning to end. Hello.
Yeah, you're audible.
Okay, from the beginning from the basics things till the recent advances, we'll see in this presentation today.
Go ahead.
Okay, should I start?
Yes, yes. Yeah.
Good afternoon, everyone. I am starting my presentation from today's my topic is necrotizing enterocolitis, and my moderator is Dr. Snehal Patel and the mentor is Dr. Sachin Shah. Okay, as we know, NEC is the most common life-threatening emergency of the gastrointestinal tract in the newborn period. The disease is characterized by the various degree of mucosal or transmucosal necrosis of intestine. Incidence being 2 to 5% of very low birth infants. If you see in Indian scenario, it is 5 to 10% in very low birth infants. It is 1 to 8% of admission to the neonatal intensive care and 14% of infant under the 26 weeks of gestation, less than 1% after 32 weeks. Overall mortality is 30 to 50%. In Indian scenario, overall mortality is being at around 20 to 40%. Risk factor for the NEC are divided into three parts, that is antenatal, perinatal, and postnatal. Antenatal risk factor includes preeclampsia, that baby is not, mother is not covered with the antenatal steroids, and maternal chorioamnionitis. Perinatal risk factor includes IUGR with or without Doppler abnormalities, that is absent or reverse and diastolic flow. And second is fetal distress. Postnatal factor include the prematurity is the most common risk factor for the NEC. Second is low birth weight infants. Third is perinatal asphyxia, formula feeds. As we know, Cochrane reviews suggest that formula feed versus the breast milk, that is the more than 2.8-fold times increase in mortality for the babies who are formula feeds compared to the breastfed infants. Patent ductus arteriosus, neutral sepsis, abnormal gut microbial colonization, anemia, liberal food intake, drugs that are broad spectrum antibiotics, H2 blocker, ranitidine, caffeine, steroids, indomethacin, and some are unknown in significance like umbilical arterial catheterization and PCV transfusion. For PCV transfusion, I want to add some points that's called TRAGI. That means the transfusion-related acute gut injury. A significant association between red blood cells in the transfusion and NEC has been reported in recent retrospective studies with about 20 to 35% cases of NEC occurring within 48 hours of PCV transfusion. The pathogenic mechanism is uncertain. It is hypothesized that the intestinal vascular autoregulation occurs after the correction of anemia, leading to the transfusion-related acute gut injury. And there are some studies which supports this one.
Dr. Parth,
Yes,
I would
ma'am.
like to ask at this point of time. So
Yes,
what is the threshold you would
Hmm.
like to keep in a baby, in a premature baby for a transfusion first? And second, whenever you are giving a PCV transfusion to this child,
Yes,
right?
ma'am.
So would you stop the enteral feeding for that particular period of time or no?
Ma'am, that studies they are suggesting that the 25 to 35% NEC occurs within the 48 hours. So in less than 32 week child, I will like to stop the enteral feeding for a time being, at least after 12 hours of infusion of PCV.
Right, right. And what about the transfusion threshold? So what transfusion threshold you are keeping and what are the guidelines?
Ma'am, that is depend upon the respiratory support for the different babies, ma'am.
So basically, it would be like that. If it is a stable baby, you can keep a transfusion threshold at around 7.5, right? Okay. And if it is an unstable baby, then you can transfuse the baby when the hemoglobin is around 9, right? Okay. So this is the new guideline.
Okay. As we know that the pathogenesis of the necrotising is multifactorial. It includes the intestinal immaturity, immature host immune system, enteral feeding, that is hypertonic formula, dysbiosis, altered intestinal microbiome, and gut ischemia. And some leads to genetic factor. All this leads to the inflammatory mediators, and ultimately it leads to the gut GI mucosal injury. The recent advance in pathophysiology of NEC is TLR4, that is toll-like receptor 4. Excessive intestinal inflammation is due to the immature innate immune response, and expression, localization, and signaling of TLR4 in colonic epithelium may be developmentally regulated. Prevention of endoplasmic reticulum stress reduce the TLR4 mediated intestinal stem cells, apoptosis, and mucosal disruption. These changes suggest that increased ER stress within the premature bowel predisposes the NEC. These are the recent advances in the pathophysiology of NEC. One more thing, that decreased diversity, complexity, and stability of blood flow, that is dysbiosis, and delayed colonization by the beneficial microbes. Intestinal epithelium integrity is controlled by the tightly regulated balance between the proliferation and differentiation of the epithelium from the ISC and cellular losses by apoptosis. It involves the various signaling pathways. Pathological changes in NEC, most common changes is coagulation necrosis, for inflammation, and bacterial overgrowth. Increased mucosal permeability leads to the translocation of bacteria and inflammatory mediators causing the systemic circulation. Site of the NEC, NEC can occur any site from starting from the duodenum to the rectum, but most common site is distal part of ileum and proximal segment of colon. In fetal case, gangrene may extend from the stomach to the rectum. Clinical presentation, NEC usually present in second or third week of life, but can late as 3 months in very low birth infant. Age of onset is inversely related to the gestational age. In less than 29 weeks, it is 14 to 28 days. In term babies, 6 to 8 days. And mean duration for presentation is 12 days in 29 to 31 weeks of babies. It present as either purulent or rapidly progressive illness, or by slow proximal illness with abdominal distension, feature of sepsis and ileus. These are the common signs and symptoms of NAC. It includes in local signs, that is GI signs, and systemic signs. GI signs include abdominal distension, abdominal tenderness, increased aspirate, vomiting, blood or bile stain, occult blood in stool, diarrhea, erythema on the abdominal wall, or absent bowel sound. In systemic signs, there are non-specific initially: sick looking, lethargy, temperature instability, increased episodes of apnea and bradycardia, and acidosis and glucose instability, either is hypoglycemia or hyperglycemia. Child may present with the feature of shock and DIC. Investigation, the routine first most common investigation is being abdominal radiography. We have to take either AP or lateral deep venous vein, and finding includes first is bowel wall edema. So it is non-specific find. Second is pneumatosis intestinalis. It is the pathognomonic for the NAC. Third one is portal of hepatic venous case. And the fourth one is in stage 3B, there is a perforation leads to the pneumoperitoneum, taking appearance of gas under the diaphragm.
What you're
Yes,
saying, yeah, you have written here fixed position of the bowel loops, and that you can say it's a sentinel loop sign.
Yes, ma'am.
Yeah.
And the frequency of X-ray depend upon the severity of NAC. It vary from the 6 to 24 hours at the time of any deterioration. That when we do other investigation like blood investigation, that is a classical triad for the NAC. It includes the thrombocytopenia, persistent metabolic acidosis, and severe refractory hyponatremia. Other includes the anemia, neutropenia with a shift to left. Third one is when you do the stool analysis, either OBT may be positive, and blood culture may reveal the pathogenic organism, but the positivity for the blood culture is only about 40%. USG abdomen. Studies have shown that sonographic finding may allow earlier and more precise diagnosis of NAC. There are the different USG finding in NAC, like includes free abdominal fluid, thick bowel wall, thin bowel wall, portal venous gas, intramural gas, a reduced peristalsis, the absence of peristalsis in certain area, increased perfusion of bowel wall, and absence of bowel wall perfusion. The recent advances that study is being conducting about the hepatic blood flow in NAC. The aim of that study is to evaluate the portal or hepatic vein flow in NAC, and the conclusion being diagnostic ultrasound useful for the diagnosis and follow-up of the NAC by providing the quantitative information on the hepatic blood flow. The daily portal blood flow and hepatic blood flow ratio measurement in neonate with NAC may be beneficial to make decision of starting enteral feeding. And one more is abdominal near infrared spectroscopy. Aim of this investigation is to use the NIS to establish the normal values for the abdominal tissue oxygenation in preterm infants and test whether they reduce in infant who develop the NAC. And results are mean abdominal saturation in normal preterm infant during the first week of life was significantly higher in those who later developed the NAC. The abdominal tissue saturation less than 56% identified those with progressing NAC, and abdominal tissue oxygenation is less than 50% independently associated with the significant increased risk of NAC. Infant with the NAC had significantly more variation in abdominal tissue oxygenation during and after feeding in first 2 weeks of life. And some blood investigation that include the lead score. It stands for the L for liver fatty acid binding protein, I for intestinal fatty acid binding protein, and T for trefoil factor 3. And other biomarkers includes the interleukin-8. The studies show that lead score can effectively differentiate surgical NAC from the non-surgical NAC infants and non-survivors of NAC from the survivors at the onset of the clinical presentation. Serum concentration of LFABP, IFABP, and interleukin were significantly higher in infants with the NAC compared with the controls. This is the modified Bell staging. It includes the 3 stages. Stage 1 is suspected, stage 2 is definite, and stage 3 is advanced. In each stage, there are 2 groups, that is A and B. In stage A there are systemic signs. It includes the temperature instability, apnea, and bradycardia. And local signs include the non-specific signs like mild abdominal distension, increased pre-feed residues, and occult blood in the stool. Radiological signs include normal and mild ileus. Stage B, systemic signs are same, but local sign includes the gross blood in the stool. So in stage 1A and B, differentiate is presence of occult and gross blood in the stool. In stage 2A, the systemic signs remain same, but local signs include prominent abdominal distension, abdominal tenderness, and abdominal bowel sounds. The radiological sign that is pathognomonic of the NAC is pneumatosis intestinalis and ileus. Stage 2B have, apart from this, in systemic signs, metabolic acidosis and thrombocytopenia. In local signs, abdominal wall edema, palpable loops, and abdominal tenderness. Radiological signs, that apart from the pneumatosis, that is portal vein gas. In stage 3A, that is called advanced stage, this stage have feature of shock, DIC, and mixed acidosis, along with the local signs like abdominal wall erythema, induration and erythema, marked tenderness, and there is a definite ascites in the radiological sign. Stage 3B, there is a surgical sign, that is perforation. Systemic sign includes the worsening of the stage 3A sign, shock and DIC, and radiological sign showing the pneumoperitoneum. The differential diagnosis for the NAC is most common is feed intolerance. How will differentiate between NAC in feed intolerance? In feed intolerance, there is no systemic manifestation and normal investigation. Condition improved with the holding of enteral feed or reduction in the feed volume, administering parental nutrition antibiotic for the 12 to 24 hours. Second most common is spontaneous intestinal perforation. SIP occurs in usually first week of life, even with it normal or no enteral feeding. It presents as
you can go a little slow because
Okay.
people can't understand what you are telling.
Okay.
Because very fast going, little
Okay.
bit slow. That
Okay.
those who are listening can understand what you are telling.
Okay, sir.
You can go for the differential diagnosis first and then second.
Okay, sir. The first differential diagnosis is feed intolerance. We can differentiate feed intolerance from the NAC. Is in feed intolerance there are no systemic manifestation and the investigations are normal. In condition, this feed intolerance is improved with the holding the enteral feeding or reduction in the feed volume, administrating the parental nutrition antibiotics for 12 to 24 hours. As I told you that the second most common differential diagnosis is SIP, that is spontaneous intestinal perforation. SIP usually occurs in first week of life with no or minimum enteral feeding. SIP present as an asymptomatic peritoneum, pneumoperitoneum. As we see that in NAC we have some local sign, systemic sign, and while in SIP there is a directly that baby can present or unit can present directly with the pneumoperitoneum. Baby will have more stable in SIP than NAC. And site for the spontaneous intestinal perforation is terminal ileum without significant inflammation. It is not accompanied by the extensive intestinal inflammation or necrosis, and post-operative recovery is usually uneventful. There are some risk factors for the SIP that includes the postnatal steroids and indomethacin for the treatment of prophylaxis PDA or treatment of PDA. Pathophysiology, when you do biopsy, that in NEC there is a transmural involvement, while in SIP there is a focal thinning or absence of intestinal muscularis propria. Third is most common is sepsis. Third most common is sepsis. In sepsis, abdominal tenderness characteristics of NEC is absent. And some surgical condition also mimics like NAC, which includes the bowel atresia, malrotation with obstruction, malrotation with mid-gut volvulus, gastric perforation, and mesenteric wall thrombosis. Management for the NAC, it is depend upon the stage. So for commonly for stage up to stage 3E, there is a medical management, and in stage 3B, there is a surgical management. So we'll start by step. Suppose child is having any umbilical artery or venous catheterization, we should remove that. We should keep the neonate nil per oral. In stage 1 is for 24 to 48 hours. In stage 2B or 3A for 7 days, and 3B is for 14 days.
Parth, it
Yes,
is
ma'am.
not cut-to-cut guideline, dear.
Yes,
For NBM status. So if it is a stage 1 and you are kept the baby NBM for 48 hours and still you are seeing that, you know, the color of the abdomen is not good, the child is still, lethargic and apnea is going on. So in this child, and if you are finding that abdominal distension is still on, you can just increase the duration of an NPO status of the child. So it is not cut-to-cut guideline. So you just can say this is an average period, but not the definite period the child should be NBM at that point of time. And second, I would like to add, if you are finding a portal gas, that is a poor prognostic indicator. So
Yes,
even in the stage 1, stage 2B, if you are finding a portal gas, you can extend the period of NPA for 7 to 10 days at least, right?
And that ma'am, this portal vein in X-ray.
Yeah.
Or in USG also.
In both.
Okay.
Both.
Continuous decompression of stomach and volume to volume replacement with the N/2 saline, by the half saline. We should start total parenteral nutrition in stage 2 and stage 3. Antibiotic depends upon the NICU protocol with anaerobic cover when there is evidence of peritonitis or bowel perforation. And duration, there is in stage 1 is 24 to 72 hours, stage 2A that is 7 to 10 days, and 2B and higher around 14 days.
You need to take care of your potassium values as well at this point of time. So when you are giving a volume to volume replacement with only a 0.45 NS, then you have to consider the potassium as well. You just check your potassium regularly. That is also very important for your intestinal motility.
That is coming supportive management, ma'am. That NEC child should support from the all system, like respiratory in form of CPAP or mechanical ventilator, cardiovascular. We suppose child required volume in the form of NS boluses or different inotropes. Hematological, we have to maintain hematocrit FFP. If required, PEG cell transfusion. If there is evidence of DIC, platelet transfusion, FFP transfusion if required. Then suppose that, as ma'am told, that metabolic correction should be considered, and metabolic acidosis will generally respond to volume expansion. There are rarely need of soda bicarb. It is reserved for the severe metabolic acidosis. Electrolytes management.
Again, a caution. Be very cautious and giving your volume boluses. You can just not give an expansion very fast, because one of the manifestation of PDA is neck. So if you are giving a volume boluses at that point of time, you are, actually increasing a PDA kind of a problem to the cell. So just do a echo at that point of time, rule out your PDA. If you feel that volume expansion is going to help the child, you can give. Otherwise, be cautious in giving the volume boluses, right?
Family support, as we know, it is a painful condition for the family also. The child is staying in NICU and developing this type of complication. So any family of the infant in the NICU may overwhelmed by this crisis, and careful anticipatory sharing of information must be utilized by the alliance with the family. Monitoring abdominal girth and serial abdominal exercise, as we told, it depends upon the severity of NIC, 6 to 24 hourly or as needed. Vitals, that all vitals should be monitored. Urine output, urea, creatinine, serum electrolytes, and surgical intervention. As that study suggests that in all, 20 to 50% of infants with NEC require surgery. The indication for the surgery, the definite indication for is that is stage 2, 3B, and GI perforation. But there are some clinical parameters. When we have found there is a clinical deterioration or presence of necrotic bowel, which were indicated by that is a worsening of abdominal finding, intractable shock or metabolic acidosis, persistent of thrombocytopenia, rising leukocytosis, or worsening of leukopenia. These are a relative indication for the surgical intervention. In surgical intervention, there is a two procedure, that is resection with enterostomy, or in very early extreme low birth infants and extremely unstable infant, percutaneous peritoneal drainage under the local anesthesia. There is study, the 2 RCT compared with the laparotomy with PPD as an initial surgery in NEC. There are 2 trials, that is NEC STEP trial, and second one is the NET trial. This both trial that suggestive of there is no difference between the mortality in terms of 19 days and morbidity in PPD versus laparotomy. But in both studies, there are suggestive of that 50% neonates required laparotomy, who is in whose there is a initially drainage was performed. Prognosis. In uncomplicated cases of NEC, the long-term prognosis may comparable with that of other low birth infants. Infants with stage 2nd and 3rd have higher incidence of mortality, growth delay, and poor neurodevelopmental outcome. NEC requiring surgical intervention may have more serious sequelae, including mortality secondary to infection, respiratory failure, and parenteral nutrition associated hepatic disease, rickets, and significant developmental delay. Sequelae for the NEC, it also says as GI sequelae, This sequelae is most commonly after the surgical intervention. It includes strictures, occurs in 25 to 35%, common in large bowel, enteric fistula, short bowel syndrome, malabsorption, chronic diarrhea, dumping syndrome related to the loss of terminal ileum and ileocecal valve, fluid and electrolyte losses with the rapid dehydration, hepatitis or cholestasis related to the long-term parental nutrition, and metabolic sequelae like failure to thrive, metabolic bone disease, problem related to the CNS function in very low birth infant, neurodevelopmental delay. Recent advances in treatment, it includes the studies going on for the stem cell therapy. Amniotic fluid stem cells prevent the developmental ascites in neonatal rat model of NAC, and amniotic fluid stem cell improve the survival and enhance repair of damaged intestine in NAC via COX-2 dependent mechanism in rats. As I told you in the beginning of my presentation, that prevention is always better than cure. Prevention for NAC includes the antenatal steroids, avoidance of acid blockade, and antibiotic stewardship. Fourth one is standardized enteral feeding guidelines. So each and neonate and everything has the written guidelines for the starting of the feed, how to increase the feed, and when suppose any signs of feed intolerance or local signs of NAC suspected, what to do. The most common study that done by Patole et al. They include the timing of start feed when there is a no respiratory assistant or mean pressure less than 10 centimeter or no PD or sepsis, no need for cardiovascular support. They have started with intermittent bolus, not the continuous gavage feeding by nasogastric tube, and feeding type is usual for express breast milk included in these studies. Volume is 0.5 ml per hour in less than 28 weeks and 1 ml per in more than 28 weeks. Then increment, they started with 0.5 ml in 12 per 12 hour and less than 28 weeks.
You are not audible, Parth.
Hello. Yes, sir. I am audible. Hello.
Yeah, you're audible now.
Okay.
You're audible.
Okay.
Parth, you are not audible.
Sir, he is audible, I think. Can you please check your status? Hello.
Hello. Yes, ma'am.
Yeah, Parth, you are audible to me. Sir, is he audible to you now?
Now audible.
Okay.
But Parth, you last few minutes it was not audible.
Okay. The maximum fluid volume included this 170 ml per kg per day, and in this study they have not included enteral feeding, minimal enteral feeding, that is MAN, and they have defined the feed intolerance. Plan for actions for sepsis is when they have found that there is a sepsis, they have stopped the feeding for 48 hours and until the child becomes the hemodynamically stable. Plan for action of PDA, stop feeds until 24 hours, completing the indomethacin therapy, and stop feeding such aspirates are persistent. So in each and every NICU had some guidelines. There should be standardized enteral feeding guidelines.
Why you are leaving? If there is any relation between this feeding guidelines and NEC, that's why you stress on this.
Yes, sir. That the studies have found that when there is a standardized enteral feeding guidelines in particular NICU, the incidence of NEC is very less.
Yes. Okay, that's fine.
Yeah. And again, Parth, when you are starting the feeds, initially for the IUGR babies who is a high risk factor for developing NAC and all, the people were doing, SMA flow and hepatic flow and then checking, and then accordingly they were starting with the feed. But nowadays it has been proven that starting the MAN will improve your, the gut bacterial flora and will reduce the dysbiosis, which is a risk factor for developing a NAC. So nowadays, we are going more towards more and more towards a minimal enteral nutrition without checking the SMA and hepatic artery flow. And we are starting with that. Okay.
Okay.
Parth, what is minimal enteral feed?
A minimal enteral feeding is that is the starting of 1 to 3 ml per kg per day feeding for the infants. It helps, as ma'am told, it helps in the
minimal 1 to 3 ml per kg per day. So it's for 1 kg child, you will give only 1 ml.
Not 1, that is 10 to 20 ml per kg per day, sir.
So it is minimally 8 to 10 ml per kg per day.
10 to 20 ml per kg per day.
1 ml per kg. Minimal is 8 to 10. If I'm wrong, someone can correct. Okay, go ahead.
Probiotics. Probiotics
So-
compete. Yes, sir.
Go ahead.
Probiotics compete against the pathogens, tightens the gut barrier, and upregulates the cytoprotective genes. It decreases the inflammation and regulates the immune cells. A meta-analysis of 30 RCTs and 14 observational studies show the significant reduction in severe NEC with relative risk of 0.57. A Cochrane review concluded that probiotic supplementation in premature infants is associated with the decrease in both overall mortality and incidence of NEC. However, in the recent trials, it failed to show the benefits. Neither the large probiotic in preterm baby study, that is PIPS trial in the UK, nor the ProPrim trial in Australia demonstrate any reduction in death, sepsis, or NEC in infant below the 28 weeks of gestation.
Can we actually wanted to discuss something on probiotics? Can you go back? So the issue with probiotics is that when you look at only data from LMICs, so when we say that the pathogenesis is related to dysbiosis, so each area, even India, has its own unique microbiome. So the efficacy of a particular probiotic species would differ between different countries when you think like that. So only meta-analysis that was there was by Dr. Deshpande in 2017 from LMIC. It showed benefit. But when you look at SGAN and AAP guidelines, both of them do not actually recommend routine probiotics. That is because when you look at individual species, they did not find any individual species benefiting from probiotic in preterm babies. We have done another network meta-analysis from all LMICs. And when you look at individual species, the probiotic strain that has been shown to benefit by SGAN is Lactobacillus GG, Rhamnosus GG. And none of these studies in LMIC have actually looked at it. So it is prudent to say that what probiotics should we use in India depends on whether we are getting pharmaceutical grade probiotics or not, because they are not under any medical grade pharmaceutical laws. They are actually coming at food supplements. So they are only FSSAI approved. So that is also another point that one needs to think before instituting any probiotic into their NICUs.
So Akash, what you
Right,
use
sir.
in your NICU?
Exactly the
Sir,
same
at
question.
present we are not using it, and after looking at the data from 30 studies from LMICs, we are actually we are planning a study, because there are only 2 species that have been recommended by SGAN, and one of them has not been used in any of these studies. So it is always better that it is better that we prove that it is efficacious and then only go ahead. There is a lot of issues with cross contamination and issues with whether really that product contains that much amount of probiotic. So
recently, Akash, recently the Lactobacillus GG drops are also available.
Yeah, it is available. Sir. Yes.
So it's a very easy to administer.
Yeah, sir.
Amount and drugs availability was an issue.
So we can use that, but there is no data to support that. Yes.
Parth, if you want to start prophylactic, at what time you will start probiotic in a preterm baby for prevention of NEC? At what time you will start?
As early, sir, within 1 week, sir.
The early means at what time? Which day of life you will start?
Usually within 1 week, sir.
No. Once you start and baby start tolerating feed, then you can add on. Right.
So adding to that,
are there any papers or publications suggesting the timings as sir is asking?
Yes. So actually there are many QI studies from the West that have looked at reduction in NEC by bundled approaches. So they have different regimens in which based on what day they have started probiotics. So, but again, when you ask them, the majority of the IUGR and placental insufficiency babies have been excluded from these trials, and these are the patients that we cater to in majority of the situations. So those babies are at risk of NEC, and within 7 days, say we start feeds, and those are the babies that need probiotics, but they haven't been studied that well. So again, it is a bit of a
gray line.
Yeah.
Great. Anyways, go ahead, Parth.
The another includes that lactoferritin. The beneficial effect of the breast milk are like to be secondary to the antimicrobial properties of lactoferritin. Supplementation of lactoferritin with or without probiotics has been shown to reduce the incidence of late onset sepsis and NEC. And the 7th one is that L-arginine. Arginine is the substrate for the nitric oxide production and may help in prevention of NEC. But still that studies are going on for these 2. But still not recommended.
Okay.
The last one is, but most important, is human milk feeding. How human milk feeding is preventing for NEC? It reduces the gastric pH. It increasing the gastric intestinal mortality. It decreasing the epithelial permeability. It altering the composition of intestinal bacterial flora. So there are so many studies that differentiate between the when they have benefit of human milk diet that reduce the NEC compared to the formula feeding.
Right. So when you are planning to give a donor milk to the child,
yes,
whose mother is not producing enough and you do not want to start with the formula, so do you have any consent form in your unit to to start with the donor milk formula first?
Yes,
and second, and second, are you using a pasteurized donor milk or no?
No, ma'am, we are not using any pasteurized donor milk.
So in the last IPA as well, there was a session on the same, and we discussed that because of an increasing incidence of a CMV and all, now it is mandatory to pasteurize the donor milk before giving, and consent is most important.
Yep.
So just take care of this aspects. Yeah.
Okay. Take home message from my today's seminar is NEC is the most common gastrointestinal emergency in neonates with the high mortality and morbidity. Primarily occurs in healthy, growing, feeding premature infants. Commonly occurs in the 3rd week of life. It has the variable presentation. Bell staging criteria defines the different stages of NEC. It had the classical triad of thrombocytopenia, hyponatremia, and metabolic acidosis. Neonates with the exclusively breastfeeding have reduced risk of NEC. Probiotics have shown to decrease the incidence of NEC in previous study, but now it has been shown there is no difference between this one. And POCUS, that is point of care ultrasound, has been found to be useful for the early and precise diagnosis for NEC, and prognosis depend upon the severity of illness.
Perfect. Very nicely presented, Dr. Parth. I must compliment you.
Thank you, ma'am.
You have covered all the aspects. Now, I would welcome the comment of an experts, then we'll go with the questions. So Dr. Kamal sir and Dr. Akash, do you want to say anything on this? Hello? Hello, am I audible?
Yes, ma'am, you are audible.
Yeah. So
Kamal sir, you are not audible. Can you please speak first? Yes.
Kamal sir, unmute.
I think there is some issue with Kamal sir.
Yeah.
Meanwhile, I can comment if
yes,
sir
please,
sorts
Dr.
out.
Akash. Yeah.
So I think he covered majority of the topics, but again, I think it was the time was a little less to completely do justice to the topic. One of the things that I would like to stress on is that when we look at majority of the risk factors are actually associations, not causal associations. So when you look at blood transfusions also, so as he said that blood transfusions may be associated with gut injury, but the recent 2 large trials on blood transfusion between low and large thresholds was ETTNO, that was a German neonatal network, and top trial from NICSD NRN. Both of them actually showed that whether you transfuse on a low threshold, keeping a low threshold, or when you transfuse at higher threshold, the incidence of NEC was similar in both the groups. It was 5 and 6% in the German neonatal network group, and NICSD and NRN it was 9 and 10%. So really did not matter whether this blood transfusion, whether you gave it at 7 or 10, it did not affect the incidence of NEC. So we really do not know what is the exact cause of this phenomena. We postulate that it is due to perfusion and reperfusion injury, but which neonates are at risk, we do not know exactly. I think. And second thing is,
okay, fine. So,
any experience of LIT score where it is done for infrared spectroscopy for what we discussed? Anyone has any idea? Because I have never gone for such test.
So we were doing
so
NIRS.
Available here or not?
So we were doing NIRS at Kokilaban. Hello. We were doing NIRS at Kokilaban when we were doing a cardiac surgery to see the brain perfusion status. But for NAC, we have never done.
Hello.
Or just stop screen sharing.
Pat?
Yes, ma'am.
Yeah. So can you comment on this?
Ma'am, in our unit also we are not using this one, but we are using POCUS.
Okay. So how frequently you are doing the POCUS in suspected cases?
Ma'am, we have the expert. So in less than 28 weekers, we'll see that SMA and hepatic blood flow. Okay, and when found that there is a cutoff for this one, then we'll hold for the feeding for some time. So when we have the IUGR babies, in whom that is a absent or reverse diastolic blood flow, we'll hold for feeding for the 24 hours. But for needs we are not doing, ma'am.
Okay. Yeah.
So actually, issue with
So
doing SMA flows would be that child has already experienced ischemia in utero. Say if the mother had PIH or eclampsia, so now we would be in reperfusion phase. So the flows might be still normal. So it is not that you can clearly differentiate which babies would get harmed by giving enteral feeds at that time.
Yeah, and that's why, MAN has been stressed at that point of time. So you should start, feeding at that point of time rather than, waiting for 24-48 hours. Kamal sir, are you giving a donor milk, because this is a hot topic nowadays?
Yeah,
and
we are doing donor
yes, sir.
milk.
So are we pasteurizing or not, sir? And what is your comment on this, Dr. Akash?
Because pasteurization is not possible, but we are giving the mothers who are willing to give
with the mutual consent.
The other
with the mutual consent. Okay. What is your experience, Dr. Akash?
Yeah,
so we have our own milk bank and pasteurizer. So every donor milk is pasteurized first. In places where it is not available, the traditional way of doing it was what we used to call as wet nursing. So anyway, I feel wet nursing with consent is better than formula or IV fluids. If the pasteurization cannot be done at all at a remote place, then it may be better to give some other mother's own milk rather than giving formula. But then again, it is a difficult situation.
I think it's a topic of controversy, and I think there are multiple studies which has been proved that the incidence of CMV, and in the Western countries the incidence of HIV is much more, and it is legal to pasteurize the milk before giving to any of the baby. So yeah, I think pasteurization is must nowadays in our country as well. Yeah. So regarding the baby who is having shock and neck, volume boluses optimization and checking a PDA and all is a must. Any take home on this by Dr. Akash?
So, ma'am, again, it would be a multimodal approach. So, whether the NEC was or the hypoxic injury, ischemic injury was caused by PDA, or it was the other way around, that there was some infection that caused the PDO to open up and ischemic insult to the gut. So, again, fluid boluses we generally do not give if there is a lot of third spacing, and we feel that it has been there is definite fluid loss, whether it is in the bowel or there are a lot of gastric aspirates, then one may consider fluid bolus, but we don't usually give more than one fluid bolus even in NEC as such. And PDA, it has to be seen whether the cause is PDA, then only we'll go ahead with the closure. Again, there are no IV alternatives in India. Even if you want to close, there are only enteral alternatives. Paracetamol, in my opinion, doesn't work very well in less than 28 weekers. So we usually go for enteral ibuprofen, but again, not in cases with NEC or who are not on feeds.
Absolutely. So how many times do you have to go for a surgical ligation of a PDA? And this kind of a cases with neck, and you cannot give any enteral.
I haven't done it, at least in Jaipur. I haven't done it yet. No.
Okay, fine. So we have done 3-4 cases at Kopilaban, and it was like, it was good enough. Yeah. Yes. The next question to Dr. Kamal, sir. Sir, when we are optimizing the feeds, we are discussing about EUGR, and we want to optimizing the enteral feeds of this baby faster. We normally recommend that we have to start with an amino vein and intralipid very early in this babies to prevent an EUGR, and starting with an minimal enteral nucleation fast and escalate it rapidly. So how rapidly you want to escalate it, sir? Can you please give a brief guidelines on this? Kamal sir, you are mute, sir.
Okay, please. Any
Sir, I've
question?
asked.
Because I am
Sir,
not able to hear properly.
Okay, sir.
I am audible.
So I was just, yes, sir. I was just asking.
Is I audible?
As we are, yes, sir, you are audible. Hello. Are we audible to you, sir?
I am audible. Yes.
Are we audible to you, sir?
Yes.
Okay, fine. So I was just asking that we are, talking about, EUGR to prevent an EUGR babies, and we want to, escalate the feeds, enteral feeds in this babies a little faster. We start with the TPN and the tiny babies. So you're not able to hear? Okay, Dr. Akash, can you please take up this question?
Yeah, sure. So the question is
feeding
that,
guidelines, yeah.
so to prevent EUGR in ELBW, how quickly can we escalate? Is that the question?
Yes, and at the same point of time, we have to see the risk of the neck in this baby. So, what would be the ideal guidelines for the same?
So again, for very preterm babies between 1 to 1.5 kg, if there are no other contraindications to feeding, contraindications being bilious aspirates, not passing stools, or any surgical gastrointestinal conditions, we usually start with full feeds. So no parenteral nutrition between 1 to 1.5 kg. Less than 1 kg, between 800 grams to 1 kg, the management would probably differ between corporate hospitals and large government setup hospitals. So for us, repeated pricking or establishing repeated IV lines is an issue. So we usually, if the child is between 800 grams to 1 kg and there has been no PIH or Doppler changes, we usually start with 20 to 30 ml per kg on day 1 and escalate at 30 ml per kg each day. Say if there have been Doppler changes or the child is less than 800 grams, the rate of escalation varies daily depending on the clinical examination from 20 to 30 ml per kg. So generally what we envisage is to reach full feeds by day 7. That is what we try. And we generally do not do any screening Dopplers or screening USGs. It is just based on clinical examination and daily feed tolerance, abdominal girth measurements, and bowel sounds. So EUGR is part and parcel, I think, of Indian neonates a little bit. And completely, if the child is completely on parenteral nutrition, then also I think 40 to 50% of those neonates would also end up being EUGR. But I think if they will catch up in future by 1 or 2 years of age, so that is okay, I think.
Right. Thank you, Dr. Akash. The next question is to Dr. Kamal, sir. Sir, am I audible now?
Okay.
Hello?
Am
I audible now?
Yes, yes.
Yes, sir. So we have discussed the controversies about the transfusion threshold guidelines. So what you are practicing in your unit?
See, if the baby is very sick, we will keep the PCV 40. If the baby is in between stage around 30 and stable babies, PCV of 25 is okay for below 25, below 20 only we transfer. Between 20 to 30, we see the baby weight gain is there or not, and below 20 we will definitely transfer.
Below 20, you are definitely okay. Fine.
You got the answer?
Yeah, sir. Thank you, sir.
The baby is very sick. 40 PCV 40. In between the stage 30 to 40, around 8 to 10 days. On after the baby is on full feed, PCV of around 20 to 25, we target. If below that, we will give transfusion. and babies on CPAP or oxygen always 30 to 40 PCV.
Okay, fair enough. That would be always a confusion to everyone, whenever we are finding an abdominal distension and we are confused about it is just a feeding intolerance versus early neck. So how to, there would be very soft signs to pick up a neck at that point of time. So what are the criteria would you look for, Dr. Akash, in these cases?
So again, very difficult. So at a cross section at one point of time, I think it will be almost impossible. The only thing that gives way to definite NEC would be that localized tenderness, localized mass lesion, localized redness. Again, that would be stage 2B, evolving stage 2A or 2B.
Yeah.
So that is the only way.
Early,
For early NEC, even occult blood would be positive, even in if there has been some trauma while inserting OG tubes as well. So difficult to say whether stage, when you ask whether how can we differentiate between feed intolerance and stage 1 NEC, I don't think we can differentiate as such. Only the clinical course will tell. So if by keeping the child NPO, if you feel that bowel sounds are now good and there has been no hemodynamic instability, bowel loops are not visible, I think you can reasonably say that you can reasonably start and give trials of at least 20 ml per kg feeds and look for response. I think only by that, doing a challenge, if the child is clinically well, then only you can decide whether it was feed intolerance or stage 1 NEC.
Good. Kamal sir, any comment on this? Kamal sir?
I think he's having some issues.
I think good. Yeah.
You can ask Dr. Sachin also, he's there.
Hello, Sachin sir. How are you?
Hi. Nice.
Nice. Yeah, sir.
Yeah.
Any comments from your side, sir, as a mentor for this?
Yeah, see, I would just try to explain that all the setups in the country do not have the same infrastructure, same type of patients. And in private setups, all the hospitals do not have an attached human milk bank, or you can get milk easily. For example, we are most of an outbound patient unit. We get most of 90% of the babies are outbound babies, but the mother is at a very different place. She is not able to send milk on the day 1, day 2 also most of the times. And with inavailability of a human milk bank, it becomes very difficult to start these babies on trophic feeds also, even on the first day or second day. So my question to Dr. Akash would be that when we see this type of babies who are in the range of 30 weeker, quite stable hemodynamically, having mild RDS, going good on CPAP, and everything is okay, we want to start feeds, we want to put them on quite high feeds. And now we know that there are a lot of trials that we want to put them on full feeds, right from day 1, day 2 also, for a 30-32 weeker child. But if there is no availability of breast milk, then what are the options you have? Will you start with the TPN, or you will start with a formula in a graded way, or you will try to get some milk from some other mothers with some proper consent? But I'm not sure what is the correct way.
So we face similar situations as well. So we have a large outbound unit. I look after the 80-bedded outbound unit. So only few of the mothers would be with us, and majority of them would be at their primary hospitals. And majority of the babies that we cater to in an outbound unit is between 20 to 34 weeker as preterms. So we would, our philosophy is that even a child at 30 weeks at 1.2 kg, if we have donor milk availability, so because we have a criteria that whatever donor milk is with us, we'll try it and first give it to less than 1 kg babies, and then move ahead to 1.2 if we have sufficient amount of donor milk. If we do not have donor milk available for a 1.2 kg 30 weeker neonate and I want to give feeds, then we obviously give formula feeds. So we want to avoid IV fluids and pricks. That is, so based on that philosophy, we go ahead and prepare formula feeds for them as well. So breast milk is protective. Donor human milk is better than formula milk, but not is worse than breast milk. But in this same series, I would say that IV fluids is worse than formula feeds. But those feeds also have to be prepared aseptically, and all precautions need to be taken in that.
Yeah,
so
but what is your how do you grade up the formula feeds if you're not having breast milk? It is the same schedule.
Yeah, same schedule, sir. Same, sir. Okay. Meanwhile, we try and motivate. We try and motivate the attendants to bring the mother once she is well.
Yeah, but that takes almost 2 to 3 days, and we know that it takes 48, 72 hours.
Yes, sir.
So anyone of you have any experience with Neolacta? No.
I've
I've
used it
never used.
previously, but not a very cost-effective way. And I don't means it's very difficult to predict whether it is better than a formula milk or that definitely is not comparable to breast milk as such, because you see how it is being given to you, and I don't know when we prepare it and we give it to the baby, how much effective is it? But I feel that preparing a formula in a better way, in a more aseptically way, should be a better way to do that. If you're not having an access to a human milk bag, that is what I feel, and we are not using it now.
Yeah, okay, sir. So there is a question from Dr. Shivani Pandit, and she's asking the role of HMO in neck. Any comment on that, sir?
Should I take it, Sachin sir, if you want to take it?
Yeah, please, Dr.
So there have been studies which have shown that human milk oligosaccharide does result in prevention of NEC, but it is the same situation as for probiotics. See, HMO is again a food supplement, not a pharmaceutical grade product, and most of the HMOs would come with the probiotic, or the formula companies would say that their formula has this HMO. But what is the exact effect and whether that HMO is causing that effect, that we do not know. But it has been postulated that there is data that HMO does result in reduction of NEC.
Yeah, there is a question for any role of early laparotomy before perforation. So I think two studies Dr. Parth has shown. Any comment? Kamal sir, Sachin sir, Dr. Akash?
See, basically what we are seeing is that a progression of NEC from stage 2 to stage 3 is a very, very acute one. You are having all local signs and you are not sure whether this baby has perforated or not perforated. And we see a lot of studies. We know that when there is a perforation, there is definitely a need for a laparotomy. But the main result lies in when you intervene earlier, before the perforation has occurred. If you intervene, you drain, either you do a peritoneal drain or you open up the abdomen and see what part of intestine is bad, and you have to resect that part. You have to do an enterostomy. So it all depends upon how early are you intervening. But as what we discussed with the pediatric surgeons and what we have seen, that if you have a persistent local findings persisting for more than 12 hours, all the radiological signs are present, then it is better to open up the abdomen rather than just waiting and just letting the abdomen perforate. Then once you have a perforation, then as such your chances of survival is less than 50%. It's better to operate early once you are having a classical diagnosis and you are having a fixed abdomen findings of at least 12 hours, then we would try to open up as early as possible.
But if there is no perforation after laparotomy, then sir, what? It is just a negative one, no? Because there's no, improvement after that same.
See, what we have seen and what even the literature says that you have to drain. If in 2B, when you have a hemodynamic compromise of the child, the local findings are bad, you have a significant distension. And in those times, it is basically a stage which is just one stage early to a perforation. So do not want that the baby should perforate. So before that, either you put a peritoneal drain so that there is a lot of debris, there is a lot of fluid ascites collected there, we can just drain those things and it can improve. Or if you are having, we talk to the surgeons, their surgeon always want to have a look of the gut. They will tell that there is a very high chance that large part of intestine would be gangrenous inside. And once we are waiting, then we are losing very important part where we can just cut short the bad part and then we can do an enterostomy. So that is also one thought of, and what the pediatric surgeons, what we have seen is that they always want to operate early. So I think we are operating once getting even a negative laparotomy is also helpful to the child, because we are putting a drain, we are seeing the intestines thoroughly. Otherwise, there is no other way to know what is going inside.
Yeah, right.
I agree with Sachin.
Yeah. The last question is from Dr. Viraj. Dr. Viraj is asking about hydrolyzed formula in extremely premature babies to prevent NEC. Dr. Akash? There are so many, hydrolyzed formula, extremely hydrolyzed formula coming in the market. And, they are claiming for a good gut tolerance and everything.
So they do claim, and of course, pharmaceutical companies would back it, but I am yet to see the data for it. So we do not use hydrolyzed formulas for extremely preterm babies. as of now, and I don't think that there is. I would have to review whether there is such a strong evidence that extensively hydrolyzed formula should be used for extremely preterm babies if formula is being used. I don't think
Kamal
this
sir,
is the case.
Kamal sir,
May
your
I?
comment on that?
No, we also don't use hydrolyzed formula for preterm baby.
Biraj Di, yeah, you please.
Yeah, so
Hello?
not to prevent the neck, but I would say in case of feeding intolerance, sometimes it is very
Okay.
difficult to step up the feeding for this kind of a baby who are 24 weeker, 23 weeker, 25 weeker, especially 23 to 25 weeker. So we stuck up whether to increase the feed, and there is no clear-cut sign where you just want to stop, but then abdominal distension is there. It's not allowing you to go ahead. In that case, sometimes we have practically seen the results of extremely hydrolyzed formula. There were a couple of studies where it's reported that the extremely hydrolyzed formulas are beneficial in case of feeding intolerance, in case of extremely premature babies. But
So
it is
are we
not
documenting-
the
So
recommendation.
again,
It is
it
not
can be
the
tried.
recommendation.
Yeah,
It's not
it
the
can be tried.
recommendation.
It can be
Right.
tried.
It can be tried,
Yeah.
Right. Okay. Right. So thank you so much, Parth, for a very nice and crisp presentation. And I thank experts, Dr. Kamal sir, Dr. Akash, and Dr. Sachin sir. Thank you so much. Over to you, Prashant sir.
Yeah, thank you so much, everyone, for doing such a wonderful discussion. I, on behalf of NNF Gujarat, would like to present a certificate of appreciation. Deblina, can we have the certificates? Yeah. So thank you so much, Parth, for being a presenter in Neonatal Pathshala. You have presented more than 50 slides in stipulated time, 35 minutes. So thank you so much for being crisp and making it a wonderful presentation. Thank you, Parth. We also thank Snehal Patel for moderating the session so well. And we also thank Dr. Kamal Parikh as well as Dr. Akash Sharma for being an expert in Neonatal Pathshala. Thank you so much to Dr. Sachin Shah for being a mentor to Parth. And thank you so much, everyone. We'll be meeting after a break of 1 week because 8th March is a Holi and we want to celebrate Holi. So no Neonatal Pathshala on next Wednesday. We'll be meeting on 15th March with PG case presentation in Neonatal Pathshala on Wednesday, 3:30 p.m. with the same ClearNet and same YouTube link. Thank you so much, everyone.
Thank you, everyone.
Thank you, Prashant sir. Thank you.
Thank you so much also. We are closing the room here. Thank you.